All right, well, we want to welcome everyone to the second part of our Cornea session. This is going to be our Pardon the Interruption session. I want to thank my co-host, Dr. Ed Holland, for joining me. You want to explain the format?
So we're going to present a series of cases that are very common. It's not to trick the audience or trick the panelists, although the panelists usually trip up on most of these cases. And we're going to present the case and have you vote on how you want to treat it, and then the panelists will kind of discuss whether they agree or disagree and hopefully get some good discussion with the panel.
Yeah, and I want to thank our panelists for their excellent talks today and also participating today. I also want to welcome a new member who wasn't able to join us last year, Eric Donenfeld. I think you were busy working on your putting last year, Eric, but I'm glad you were able to join us this year. And just a few minutes on Eric. You know, we all know Eric. He's a key opinion leader. He's a very influential figure in our field, and, you know, whether he's talking about a new antibiotic or a new surgical instrument or a new surgical technique, we all seem to come up to him afterwards, ask him about it, and he starts a trend. And I don't know, I've kind of coined this the Donenfeld effect. Ed, do you have you any experience with the Donenfeld effect?
Yes, he's a key opinionated leader, and if we could, the Donenfeld effect, if we can have the next slide, when Eric opens his mouth, typically what happens is there's an immediate headache by the clinician, you know, a really distraught feeling, like, how the hell do I get out of here? This is what we coined the Donenfeld effect.
And fall asleep.
Actually, let me explain this a little bit better. This is Steve Spears and myself discussing at the presidential reception where Ed has just been elected president of Ascus, and we're going, is Ed really president of Ascus? And you can see him in the background right there.
Okay, so you're getting the tone for this. Let's start with our first case, and we can have the gong. So all the diagnoses are listed on your right, and we're just going to go through these rapid fire, spend about 5 minutes on each. So go ahead and take your audience response system, and this is a 24-year-old with allergic conjunctivitis. How are you going to treat the patient? With antihistamine, mast cell stabilizer, that with an oral histamine, that with topical steroids, that with topical cyclosporin. So any comments from the panel? You know, one of the things that when I treat patients who typically, you get some perennial allergic patients, but typically they're seasonal, I think it's so critical to treat these patients before allergy season hits. And for us in North Carolina, that tends to be early March. Anybody?
So everybody vote.
Everybody go ahead.
I want the audience
and vote.
to vote as well.
Yeah, while we're doing this.
Yeah, I don't like any of these options, actually.
You don't like it? That's
I don't like
totally
any.
Fine. So what option would you pick then?
Well, I think a patient like this needs an acute course of steroids, so you start with that.
That's on there.
Yeah, so I'm going with steroids, but then I also like antihistamines. I like that. But my second line therapy would be cyclosporin. So I'd be going steroids, cyclosporin, and antihistamine, and mast cell stabilizer would probably be my fourth option.
Okay. Anybody else on the panel?
I do the exact same thing. Steroids and cyclosporin.
You go, girl.
Doug?
I hate to admit it, but I agree with Eric.
How about cyclosporin? Do you like it because longer term therapy? Do you keep them on it all year long for these patients?
I think it has benefit. I use it like that oftentimes.
Mm-hmm.
But, you know, Terry, something that you mentioned, you know, a lot of patients with seasonal allergic conjunctivitis will have, you know, they'll have a bad month. It's either, you know, end of May, early June in our area, and then August. So if we know they're going to get in trouble, I think you can start your mast cell stabilizer and your antihistamines as a preventative therapy.
Right.
And then when they come in with acute symptoms, the short burst courses of topical steroids, I think, work great. And again, loteprednol is a great choice because of its efficacy without some of the risks. I do think cyclosporin is kind of neglected, and I like to use that for chronic patients such as perennial allergic conjunctivitis patients, or that patient with hay fever that's symptomatic all the time. And this slide on the right shows a picture of vernal, really. Yeah. And those patients are often, you know, they often are on and off topical and oral corticosteroids, and I've found that long-term topical cyclosporin has worked great for those patients.
So the refractory atopic vernal patients, I mean, I used to formulate 2% cyclosporin 4 times a day. I mean, is that what you use, or are you using the branded version, Restasis?
No, I use Restasis. I think it works as well. It's so much easier for the patient, and I've really not seen any decrease in efficacy on the Restasis brand, so that's what I use.
Yeah, I agree. The only time I would go to a formulated cyclosporin is when I want to get a higher concentration into the anterior chamber. But for ocular surface disease, I think you're getting all the efficacy, and you have a longer contact time because of the vehicle. So We just use branded Restasis here very routinely. But the difference is, for dry eye for Restasis, we use it twice a day. But for here, you can go up a little higher, and you can use it 3 or 4 times a day as a kind of a standard therapy to get them going, and then drop it down to twice a day a little bit later on.
Yeah, and these seasonal allergy patients are really miserable, and so a lot of times I'll direct them to like pollen.com, or Weather Channel has pollen counts, because they can really follow that, and when it emerges, really start treatment, and that seems to be very helpful for these patients, because this can be miserable with the grass and tree pollens.
You know, we think about ocular surface disease, and we talk a lot about dry eye and meibomian gland dysfunction, and really, if you look at the literature, allergic eye diseases actually outnumbers those two as the most common ocular surface disease.
Right.
The majority of patients go to the over-the-counter medications and self-treat, or their primary care physician is self-treating. And so I think you're going to hear a lot more about the management of allergic eye disease. And the second point is allergies are increasing with all this environmental factors that we're seeing. The incidence of allergic, all allergies and allergic eye disease is almost doubled in the last 20 years. And so it's going to be a significant discussion in the next few years. And I think these patients are going to be, with increased attention, going to be pushed into ophthalmology and optometry offices.
Great. Can we have the gong, the ding? All right, let's do the next case.
So this is a patient with complaining of blurry vision. The patient has some irregular epithelium, ABMD, or anterior base membrane. It's really a degeneration, not a dystrophy. I refer to it as EBMD, epithelial base membrane degeneration. So if the patient comes in with irregular vision, how do you want to manage the patient? Miro ointment, drops in ointment, anterior stromal puncture, superficial keratectomy, or Super K and PTK. And let's just say, for argument's sake, the patient has a history of pain upon awakening. Please
Respond.
Please respond.
I don't like any of these options, actually.
What's the refractive error?
You're not going to get to talk.
We're going to let you put the answer choices in for next year.
What's the refractive error in this patient?
Refractive error is -2. So let's see how. So, Dr. Katzev, please respond.
Well, I mean, if you got a refractive error -2, it's such an easy thing to talk them into, hey, let's just do a PRK and solve this thing, as well as correct your myopia. And I think patients are very amenable to that, and they're willing to pay for it as a refractive procedure, and so you take the insurance out of there so you don't have to really worry about
Doug, come on,
whether it's paid.
Doug, can I just comment? Doug, why would you offer this patient PRK? You don't know the real refractions about -2. It might be -2 plus 0.5. You're going to be so inaccurate with a PRK. I think you want to address the condition first, get good maps, like 1 or 2 months later, and then come back and do it.
I'm not saying doing it right away, but that's where I'd be going.
Well, now
to
you're
treat
changing your
this patient.
story. Okay. Okay.
No, but Bill,
Okay.
you bring up a great point. I've had 2 patients now where I thought I could kill 2 birds with 1 stone and do their PRK, and I've had bad results.
Absolutely.
So you need to treat this first, and then go back and treat the refractive error if
I
you're
would
gonna do it.
definitely do that. I wouldn't go.
It's a 64-year-old too. I mean,
And
the 64-year-old is going to be developing nuclear sclerosis, and so if you can.
They're still going to have the anterior basement membrane dystrophy.
And so it may be certainly just appropriate at that time to treat just the surface and not have to do a refractive correction.
There's 2 issues in patients with EBMD, really. Number one is the abnormal epithelium causing visual loss? Like in this patient will have significant drop in vision. You have to remove the epithelium and any abnormal epithelium underneath the epithelial layers. So Miro doesn't really make sense. It's not going to improve the patient's vision. The other issue, does the patient come in complaining of discomfort in the middle of the night or upon awakening, and that means the patient's having either microerosions or corneal erosions. And actually, in those patients without loss of vision, I think you can try a trial of ointment at night, and a significant number of those patients, if you keep them on ointment every night for several months, may become asymptomatic. If that fails, I think you then move on to a surgical treatment. It's interesting the audience chose Super K over angiostromal puncture, and I think that's the right answer, because it's a diffuse corneal disease, and if you think you know where the abnormal epithelium is with negative staining you see there, you're going to be treating that area. They're just going to have irregular epithelium and symptoms elsewhere. So angiostromal puncture is a great treatment for traumatic recurrent corneal erosion, and that's the treatment of choice. But for EBMD that needs a surgical option, it's either Super K or Super K with PTK. I prefer adding PTK because I think the irritation of the anterior stroma actually keeps the epithelium adherent. Eric, you didn't like any of the choices. What do you want to do? You want to do cataract surgery or what?
Actually, I was just giving you a hard time. I like 4. I think Super K here,
Yeah.
and the PTA, in a -2 myop especially, you'll kill 2 birds with 1 stone. You'll get rid of the dystrophy, you'll regularize the cornea, and maybe you'll take the patient from a -2. And I don't only tickle this. I'm talking about 5 or 10 microns of treatment here. You're not
Right.
doing, you're not
Right.
you're not going to go
Right.
deep.
Right.
Just a very, very superficial therapy, and it may have a half a diopter of effect, but I think you get a better healing response and less likelihood it's going to come back.
Would you use
People don't have lasers just hanging around. I mean, as cornea specialists, we might. If this walks into a general ophthalmologist clinic, this is a scrape. It takes 2 minutes
Absolutely
at the slit
reasonable.
lamp. You're
Scrape.
done. You put a contact lens on, you put him on some steroids and antibiotic, and this is gone, and he's got clear vision in a week.
But Dave, the studies do show that you need to do something to the interstroma, so you can scrape and do a diamond
But
burr,
it-
but just
well, you're
a
talking
scrape
about
has a
recurrent
higher
erosions.
recurrence rate than if you do something to irritate, or as Eric says,
Agreed,
tickle
but
the
you're talking
interstroma.
about recurrent erosions. This may recur, you're absolutely right, but for the general ophthalmologist, the majority of people here, scrapes.
Well, let's say it is recurrent erosion, so you're talking about, let's say, an intrastromal puncture treatment. If the lesion was central, would you do intrastromal
I don't
puncture?
do intrastromal puncture for EBMD because it's a diffuse.
No, it's
but
a
for
recurrent
traumatic-
traumatic, but it's in the central cornea.
Absolutely.
Yes.
So you don't
If you-
worry
if-
about
As long
scarring.
as you don't obliquely, enter the stroma with a large needle, you're not going to get a scar. If you go perpendicular with a 25 or a 27 gauge, and you don't indent the cornea, all you want to do is get the Bowman's laser. You barely touch it. You will not get scarring, and you will cure the disease.
Yeah, no, very reasonable to do. The other thing I'll just mention is sometimes you see this and you say, this can't be visually symptomatic. You look at it and the patient's 20, 30. I've seen people sent for CAT scans because of this. And when you see that, 2 things. Do topography and look at the topography. You'll usually see a lot of dropout. And number 2, if you're uncertain, put a gastro contact lens on them and the vision should go right to 20/20.
But I wouldn't do the Donnenfeld corneal tenderizer device.
Oh, really?
I would
You
not
wouldn't?
use that.
All right, let's go to the next case. This is a 58-year-old patient with blepharitis, and you can see clearly the signs here. Let's do the audience
So is this
response
question
system.
primary treatment? What's the question?
Yes, the treatment, how are you going to manage this patient? This is a patient with meibomian gland disease, clearly. Are you going to use lid hygiene with warming and digital massage, topical-based lubricant as your primary treatment, topical azithromycin, doxycycline, or all above? So why don't you go ahead and respond?
I think we'll really take this one. Yeah.
Okay, great. What do you, could you add some insight into what you do with this patient and comment on the audience response?
I think the audience is pretty sharp. I would do all of the above. I think that heat and hot compresses help. Massage and expression also can be beneficial. Most patients don't like to do that, and if you can get them to do a hot compress, that's good. Lubricants don't hurt during the day, but if you can use aqueous tears, it'll sometimes help wash away some of the sebum that collects on the lids otherwise. I mean, this is, by and large, excess oil on the lid margin. So I think, by and large, ointments at night are not good, but application of azithromycin is good, and oral doxycycline helps loosen some of the secretions and prevent bacterial overinfection. So I'm with all of the above.
So did you start all of these concomitantly, regardless if it's a mild, moderate, or severe case of meibomian gland
Well,
disease?
if I started every patient on every treatment, regardless of the disease, there would be no point for me to go in the office. So actually, I use a graded approach, and we'll start with hot compresses and tears, and then add the antibiotics later.
Okay, so you start with your topical agent first?
First treatment is to be sure, now not everybody needs artificial tears, but if there's
Right.
any sign of dry eyes, you want to give some kind of artificial tear help. And if that doesn't seem to help, hot compresses will work. And not everybody likes to do hot compresses. Azithromycin is a good additive, and I've been very pleased with the use of azithromycin in many patients because it does seem to provide
And how do you
resolution of
dose that, and
arthritis.
how do you tell them to apply it?
I use azithromycin for 3 weeks in a row every quarter.
Oh, every quarter. And you have them
So,
drop it in their eye and rub it in, or?
Well, if they, that's sometimes how it goes in. I mean, I think that we're not sure how these drops go in because it's a really thick, viscous drop. I loved Eric's comments that somebody will try to give one dose and squeeze the entire bottle out, and that's, I'm looking forward to some better packaging than we've had. But it's a great drop, and it works, and I think that oral doxycycline is helpful as well.
Bill?
There's two other agents I think that can be very helpful. One is topical steroids. I use a pulse of topical steroids when they're more inflamed. And also long-term, topical Restasis can also, or cyclosporin can be very helpful as well for the long-term management of these patients.
Bill, what are your indications for corticosteroids? Because I think it's a very good point.
I mean, I think patients that are, they have a lot of surface staining, they're very irritated, so I use a lot of topical steroids in these patients.
I think your point is great, because these are patients that come to you, they've probably seen 4 or 5 other eye care specialists, and they have pain, that's why they're in, and fluctuation in vision. And it's the corticosteroids that are going to make them better faster.
Absolutely.
All these other things are going to take some time. And the other, I think, indication, if you see corneal involvement, if you see peripheral infiltration, if you see neovascularization, that patient, corticosteroids are definitely warranted in that patient.
In the TFOS paper, on this, something that I took home from that was just that the topical azithromycin I'm using earlier and earlier in that course. So I think that really adds, and I'm not getting to doxycycline nearly as often. And, doxycycline isn't without its side effects. I've had people with gastroenteritis and sun sensitivity in South Carolina. So,
What's the dosage you use and for how long?
of which one?
Doxycycline.
Well, I still use, I still go on the higher end. I know that we can use very low doses, 50 milligrams a day or even lower, but I usually start at 150 twice a day, and then I'll come off of that when I do use it.
Yeah, the TFOS paper also mentioned as first-line omega-3 fatty acids. You use that regularly, David, in those patients?
I do. I like what Heather said earlier. I like TheraTears Nutrition. It's just easier rather than people measuring things out and trying to find other sources. It's straightforward, and that's what I recommend. If they can come up with some other form of omega-3, I think that's fine.
I would just like to make a pitch for low-dose doxy. And if you use a higher dose antibiotic level, 50% of patients are going to have GI side effects. And
Yeah.
I find that 50 milligrams QD or 20 BID gives the same effect on the lids, because we're not using it as an antibiotic. And the GI side effects are very, very rare, less than 5%. And the sun sensitivity actually goes down to very, very rare. So I think you can get away with low-dose doxy and have the same effect.
I just wanted to
Doxy is available in 25 milligram tablets, too.
And we'll see some new therapeutic regimens for this. Science has some new exciting developments with LipiFlow device and probing as well, so we'll see. Let's go to the next case.
So this is a contact lens wearer that comes in with a very large corneal infiltrate, overlying epithelial defect, obviously involving the visual axis. So what's your management? You want to just start with 4th generation fluoroquinolones, don't scrape? Do you want to scrape it for culture and stain and just 4th generation fluoroquinolone? Do you want to scrape it, add a 4th generation fluoroquinolone, and then fortified Vanco and Ancef, so combination fortified therapy? Do you want to do fortified fluoroquinolone and fortified Tobra, or do you want to have fortified Tobra and Ancef and don't use a fluoroquinolone? Please answer.
I want this one. Voluntary.
You had your chance. You had your chance.
I'm requesting this one.
All right, give it to
You
Woody.
can do the comment. Raj, what do you
Well,
think about the audience?
I would agree pretty much with the audience. I picked number 3 also, although if it is really severe, as this seems to be, I would probably use the 4th generation fluoroquinolone, fortified Tobra, and the fortified Vanco. So I'll use all 3 agents if I'm really concerned with a
So
central...
tell me your
your
thought process of
sensitivity.
what each of those are
Well,
covering and why do you need them?
I'm hopeful that I'm overkilling everything. 4th generation fluoroquinolone is going to be certainly the broadest spectrum. Hopefully the fortified vancomycin or Ancef, whichever one I choose, generally fortified vancomycin, is going to give very good gram-positive coverage. And the fortified tobramycin, I'm hoping that I'll get better gram-negative coverage or additional gram-negative coverage. But if there is any issue in terms of either insurance or if I'm not as concerned that it's a real severe infiltrate, I would be comfortable going just with number 3.
Does the addition of the fluoroquinolone add anything when you're already on the Tobra and vancomycin or Tobra and Ancef, or can you reserve that for when you get some sensitivities back?
I think the one thing that it adds for the general physician, at least for me in a smaller town in California, you don't have the fortified available to you right away, and so you got to give them a 4th generation for them to take every half hour, every hour, till they can go get it. And then sometimes on the weekend, I can't even get the fortified made. So that's one issue why I got to start.
I agree
right
with
away.
Doug. We actually sit the patient in the room and have our staff give a drop every 10 minutes to load the cornea. And the other reason to do the 4th generation fluoroquinolone is penetration. Penetration is much better than fortified tobramycin. So, Of course, this ulcer is most likely to be a gram-negative, and there's some rare, Pseudomonas resistant strains, and so you could consider adding the Tobra, but I would not exclude the fourth-generation fluoroquinolone because of the penetration issue. Woody, you had a comment?
Yeah, I actually use gentamicin instead of tobramycin because in the higher concentrations, I'm using 13.6 milligrams per cc, and as many of y'all know, if you take an IV amp of gentamicin, it's 80 milligrams in 2 cc's, and we have the pharmacy just inject that into a bottle of IV gentamicin, and that comes out to 13.6 milligrams per cc, and it's easy to do. And I'm in a situation where I can get the drops, within an hour. So I would use, I think scraping is absolutely important because too many people make a mistake of treating a corneal ulcer without culturing it, and then if it doesn't get better, then you're kind of screwed because you don't know what's growing, and unlikely you're going to get any information from that point forward. But I use gentamicin because it's actually got pretty good MRSA coverage. And in the higher concentrations that we use with fortified drops, you're really throwing some of the MIC data that we would ordinarily abide by out the window because these drops are pretty caustic. And the usual MIC data that come from the hospital formulary often aren't really necessary here because the concentrations are so high.
Woody, if this case proceeds, needs a corneal transplant, would you send it to an optometrist for surgery? I'm just kidding. Let's just, I had a question. I had a question for Eric and Bill regarding the cross-linking. There have been some very interesting and encouraging results using cross-linking for recalcitrant ulcers that don't respond, whether they're bacterial, fungal. Can you talk about that, and would we have access for doing this sooner than, because it'll probably be 3 or 4 years before we have cross-linking approved for ectasia and keratoconus.
Well, I know Frank Price has an ongoing study right now in Indianapolis for this treatment, and they've had very good results for this. So it does seem to be very promising. It's going to, I think we'll be using this very early on. In a bad case like this, it would be great to, if we had cross-linking available, to cross-link them and start the antibiotics at the same time. So I think it'd be exciting, but still, I think you're right, a few years away.
Eric, have you treated?
We've treated with cross-linking for recalcitrant ulcers that are fungal or acanthamoeba, and we've had actually one good case with fungus, but for bacterial, there'd be no reason to do that. Comment that I just make is that very easy, maybe costs $30, $40, get a bottle of fortified vancomycin. Because vancomycin is something that you have to have because so commonly you're going to have resistant organisms, and we just keep it in the freezer in our office, and it lasts for a year. And you just keep it there. Next thing is that as far as your fluoroquinolone is concerned, you're worried about gram-negatives. You get vancomycin, your gram-positives are covered. You're worried about gram-negatives. The best gram-negative fluoroquinolone is actually siloxane. So siloxane is actually better than the fourth-generation fluoroquinolones against Pseudomonas.
Or Pseudomonas, right.
Yeah, for Pseudomonas. So it's very reasonable to use siloxane there, less expensive. And now if you're in an office and you don't have vancomycin available and you're in general practice and you want to use something for gram-positive coverage, I think you have to use dual therapy here. So you provide the fluoroquinolone, and then there are a variety of different commercially available antibiotics that are really readily available. Neomycin, Neosporin, Bacitracin, Polytrim. All have pretty good activity against gram-positives, and you can use that until you get the vancomycin.
Okay, great. Let's do the next case. Patient with dry eye and filamentary keratitis, and you can see the filaments on the cornea there. So if you can get your audience response, how would you manage this patient? Number 1, lubrication with topical cyclosporin emulsion. 2, add removal of the lesions with the forceps. Number 3, add soft bandage contact lens. Number 4, add topical mucolytic agent like acetylcysteine. So we can program your responses in the next few seconds. And Heather, what are you doing for these patients? And maybe you can comment also on the audience's response.
I think these patients do good with a soft bandage contact lens and topical cyclosporin, or I also like topical loaded prednol. I think a topical steroid works well on these patients. I think if you just remove the filaments and don't do anything else, they just come back. So.
Any other comments from the panel?
Terry, you got to look at
what's
this
the
whole eye.
diagnosis?
This eye has horrible lid margin disease, blepharitis. I mean, you've got to treat this eye from beginning to the end, and then you have to know how long these filaments have been there.
But the filaments don't come from the blepharitis.
No, they don't. But you need to treat the whole ocular
It's
surface.
Sjogren's disease.
Right.
I mean, it's
But you need to
severe
treat this whole ocular
aqueous tear
surface.
deficiency.
Right. I mean, I think the big one you're missing here is punctal occlusion. I mean, you're going to have to really, punctal plugs or punctal cautery, and you're really going to have to raise the tear film along with everything else in the topical steroids.
So when I see filaments, I mean, unless the patient has, chronic ptosis or patching or superior filaments, you can see with SLK, the central or inferior filaments is almost always Sjogren's disease, severe dry eye. So you want to evaluate the patient for any systemic diagnosis, and then, as Bill said, aggressive treatment of the dry eye with punctal occlusion. And in my practice, sometimes in these patients, they're already on hourly non-preserved tears, they're on Restasis, they've had punctal occlusion. We go to small symmetric lateral tarsorrhaphies to reduce the evaporative tear loss, because these patients, they just keep coming back and they're miserable
They are
patients.
miserable. Yeah, and I've actually found topical acetylcysteine very helpful. I mean, you can get it from liters or a formulating pharmacy. It's Mucomist, 10% solution, works very well 4 times a day. I tell them it does smell like rotten eggs, but generally they tolerate it well, and because these patients are very miserable, and even just removing them short term with forceps helps them.
The last thing and my last straw is the scleral lens for dry eye. I mean, I don't think you should forget that, because that can actually turn one of those miserable patients happy almost overnight, and that's a last resort. But true scleral lenses are treatments for dry eye, and it can be pretty remarkable.
Absolutely. I have another comment also. Don't forget Lacrosert. So for these severe patients, Lacrosert can be very effective and helpful. It's not the easiest technology to use. I usually have my patients use it at nighttime, so they go to sleep with it, but it can help with some of these patients.
It's interesting, I think some patients love it. Some of
Some
my
hate
most
it,
severe dry patients, they don't have enough tears to melt
Right.
and work in the Lacrosert, and they're miserable with it, and they demand
Right.
you take it out. But I think it's a reasonable option.
Sometimes, right.
Okay, let's go to the next case.
Next case, 36-year-old male with a diagnosis of EKC. So this is an acute. The patient's been symptomatic for 4 or 5 days. They come into your office. What's your initial therapy? Cool compresses and artificial tears, a topical mast cell stabilizing antihistamine, topical corticosteroids, or ganciclovir gel. Please vote. All right, Heather, what do you think about this?
I'm going to agree with the audience. I agree with topical steroids, and I also think that topical ganciclovir gel, now that we have that available, would be beneficial in this patient. It looks like the patient has a membrane there, or a pseudomembrane, so I think you should peel that and add the steroids.
So what is your indication for steroids? This patient's been symptomatic for 4 days. Do you want to always use steroids in the acute phase? Do you want to reserve steroids for certain clinical findings? How do you decide when to use steroids?
I think that I usually use the steroids right off the bat. I think that the patient's been uncomfortable. It gives them relief, especially if you peel the membrane. It helps to decrease the inflammation, and so I use the steroids right off the bat.
So Ed, I use steroids for 3 indications. If they're in pain from the EKC, it can be very uncomfortable. Decreased vision from dense subepithelial infiltrates, or membrane pseudomembranes.
Okay, so the SEIs are late, right? That's
Yeah.
second, third. So how many in the panel in the first 5 days would use corticosteroids? Just curious.
Well,
Not on everybody.
Okay, I'm worried because with steroids, I think there's a higher chance of relapsing and symptoms if you taper them too quickly. So I do tend to taper them very slowly if I'm going to use it.
Well, the most important thing is that the natural course of EKC is 10 days to 2 weeks. If you add steroids, it increases the duration of the illness for an extra week to week and a half.
Right.
So they're infectious for a lot longer if you add steroids. But in this case, I would clearly add steroids. If you strip a membrane, you are mandated to add steroids. But if you don't add steroids, the membrane just forms right back. Within hours, it'll come back right back. So here I would, but just for discomfort alone, I try to avoid it. I find sometimes for comfort you can add a non-steroidal. Sometimes it can be helpful. Lots of lubrication helpful. But I basically agree with everything that's been said here so far.
How many on the panel would use ganciclovir on this case?
Absolutely, and the family members.
Right. Can I ask about stripping? Is there any data that stripping actually improves the,
Stripping of the membrane, right?
stripping the membrane? Yes.
I just wanted to-
Terry, what other stripping are you
I
thinking?
just wanted to
Eric has a
clarify
history.
that,
Okay. No, I'm not talking
do you
about
think?
Eric here. Is there any data on stripping the membrane that it actually improves the patient? Because I typically just hit them hard with steroids. I have not been removing it. I'm not aware of any studies. Just curious if there's any data or just anecdotal.
Makes you feel better.
Yeah, it's
I just wonder if
anecdotally,
the
for
membrane's
pain.
uncomfortable. I would think. I haven't had one, but
It makes the patients a lot more comfortable if you strip a membrane off because it's like a foreign body. You do have to add steroids. And I mean, again, I think you don't necessarily do everything at first, but I would try stripping the membrane and steroids first. And I think anciclovir gel is probably a good additive if they don't get better sooner. But I don't think you necessarily send these people out and have them back 2 or 3 weeks later.
There's a major epidemic of EKC in southern Florida where Bill Trattler comes from, and I'll just mention this because this study was actually out of Baskin-Palmer where they had a series of, I think, 200 cases of EKC, and they managed them, and they found that they had 2 cases of gonococcal conjunctivitis because in Bill's neck of the woods, the therapy that a lot of people use is they take their own urine and they put it into their eyes as a treatment.
Does Bill advocate
So I want
That's
to know,
a-
Never heard of that.
is this something
No,
that
that
you
is-
do, Bill, or
that's
is it
Haitian.
you recommend this?
The urine treatment has not been widely adopted.
That's a cultural thing from Haiti, actually. And that,
Exactly.
So that does happen.
But it is done, exactly.
All right, let's go to the next case. This is a 68-year-old white female who comes in with complaint of severe dry eyes. And let's get your audience response in terms of management. Are you going to use topical lubrication, soft bandage contact lens? And this is a case of superior lumbar conjunctivitis. So are you going to use topical silver nitrate drops? Are you going to use thermal cauterization or proceed right to conjunctival recession or resection? So if you can respond.
Please vote. Just notice the clinical findings of the superior corneal staining. Not many things give superior corneal staining with central and inferior cornea that looks normal. And actually, the diagnosis is often best made without a slit lamp by having the patient look down and raise the lids. I've been impressed with the fact that this is an underdiagnosed etiology. We don't often think about lifting the lid, and these patients have been treated with for dry eye and blepharitis for many, many years. And you're really a hero when you finally make the right diagnosis and do the right treatment.
David, what do you think about the audience response, and what do you do?
This is exactly what I do. There's no point truly in wasting your time with the other things, in my opinion. And you don't have to be really good at cutting out the conj. You can do this at the slit lamp. You can do this anywhere. You just have to resect that conj, and it's been by far the most efficacious thing that I do. And it's easy, and it's pretty. The relief is pretty quick. So I think number 5 is the right thing to do, and I'd skip everything else at this point.
Any other comments?
How
from the
about
panel?
topical silver nitrate? Who wants to do that? Doug?
I don't think silver nitrate's indicated anymore for this because it's too hard to control what it does. The problem here is keratinization of the conjunctiva. And histologically, you've got keratinized conjunctiva that's really uncomfortable and it rubs the lids, so you've got to get rid of it. Now, burning it is one way to get rid of it, but surgical excision is actually a little bit more precise because sometimes it's hard to tell exactly where the keratinization starts and stops. And when you're burning the silver nitrate, it's possible that the silver nitrate can get in tears and run off site.
Well, what's really important, as what he alludes to, is that these are silver nitrate drops, not the silver nitrate cautery sticks that have been out there, and this has been reported. So be careful and make sure if you're going to use silver nitrate, it's the drop
The
formulation.
silver nitrates you see in the emergency rooms to stop skin bleeders will go right through the sclera in the matter of a short period of time. I've seen 2 lawsuits from scleral perforation with silver nitrate. You know, it's thought to be due to a redundancy of the superior conjunctiva that rolls over the cornea. So anything that tightens the conjunctiva, that scars the conjunctiva, will take away the symptoms. Remember that about 40% of these patients have thyroid disease, and so if they haven't been worked up, they need an evaluation for thyroid function as well.
Long-term cyclosporin therapy here is also helpful as an adjunctive therapy to prevent it from coming back. And for treating mild cases, severe case like this, agree with the therapy. For many times you'll see a very, very mild case, and for mild cases, it's very reasonable to start with lubrication, cyclosporin, and following them.
Yeah, and also 50% of these patients also develop filaments, so keep that in mind. Let's skip the next case since Dr. Rajpal covered herpes so well. So let's go to the case after that.
Can you advance?
I am.
Oh, okay.
Yeah. It's not advanced.
Can't do both.
Here
There
we
we
go.
go.
Here we
Great.
go. So this is a patient with a history of zoster that presents with this neurotrophic ulcer, and how do you want to manage this patient? Number one, lubrication, non-preserved tears, ointment, and autologous serum. You want to pressure patch this patient. Do you want to start a patient on a therapeutic soft contact lens? Do you want to do an amniotic membrane graft? Or the fifth one you can't read there is tarsorrhaphy. Please vote. All right, Raj, let's take a look at the audience answer, and what do you think about their response?
Well, I think you have to go stepwise to some degree, and certainly you would have already done the earlier things. It seems like there's a fair amount of tissue loss, a fair amount of thinning here, so I would be fairly concerned and be fairly aggressive. I think a tarsorrhaphy is underutilized. Certainly, it's going to help. It's not going to hurt anything. Can always be opened. But I think after the tarsorrhaphy, this patient's likely to need an amniotic membrane graft. I think Procare has been a nice addition to be able to use if you need to have some protective benefit short term, but I think ultimately an amniotic membrane graft is probably going to be helpful as well.
So you say you do the tarsorrhaphy first, then the
Yes.
membrane graft, or the amniotic membrane, then the tarsorrhaphy?
I would do the tarsorrhaphy right away if I could,
Okay.
and then add the amniotic membrane graft if I didn't see improvement quickly.
And what's the amniotic going to do?
If I'm not seeing improvement, if I'm not seeing any healing. I would hope that I'm going to see healing with the tarsorrhaphy. Obviously, I'm going to be doing everything else to lubricate as well.
This patient needed a tarsorrhaphy about a month ago.
You're right.
The other thing that's very helpful here, and I agree, tarsorrhaphy is the way to go. I'm not impressed with amniotic membrane grafts for this, because this is an irreversible disease. This patient has neurotrophic loss, and the amniotic membranes I find helpful for patients who have transient diseases that need to get over a hump. There's nothing that's going to be resolved here. But I will do an advancement conjunctival flap on some of these cases, and especially if it's in the periphery and the visual axis is spared, you can actually pull up the conjunctiva, cover the defect, and that is a very good treatment for these type of treatments, similar to tarsorrhaphy and better in some ways.
And if you're going to do a tarsorrhaphy, which I absolutely agree is a treatment of choice, it should be a permanent large tarsorrhaphy. I mean, 80 or 90%. There's no reason to try to do a 20% or 30%. The majority of this cornea should be covered if you want to get the epithelium healed faster, and do it permanently, because it's going to take months for this epithelium to stabilize. And actually, this patient will end up with a profound scar, and the decision will then be, is this a fellow eye and you want to leave it as is, or should we think about surgical treatment? We've moved on to deep anterior lamellar keratoplasty for stromal disease, so we don't recommend penetrating keratoplasty anymore, because this patient will have a normal endothelium. And so that's made our surgical management much more aggressive. DALK is a much safer procedure with less complications than penetrating keratoplasty.
But Ed, for those milder neurotrophic ulcers, I don't think you necessarily have to suture them. A lot of these patients hate getting sutured for that long. If they're milder than this case.
But
I think
this patient will not be mild. This
No,
is
no,
a
no.
big
I'm saying,
ulcer.
though, not all neurotrophic ulcers need a
Right.
suture tarsorrhaphy. I mean, there have been reports of, you can glue the eyelid shut as a partial or temporary tarsorrhaphy. The other thing that's nice is I do a Botox tarsorrhaphy, where you inject Botox into the superior levator muscle, and that gives nice, sometimes a month or two of protection. They could still get their eye drops in by lowering the lid, and it fades with time in terms of effect.
It's been my experience with patching and glue tarsorrhaphy, which was really described by Donenfeld, another thing I totally disagree with years ago, and that's why we mostly abandoned it, is that it's going to take some time, and any temporizing measure, the tarsorrhaphy is open and the patient's going to go through a second procedure. Tarsorrhaphies are completely reversible. I think we don't like to do it because it's an imposition for the clinician. So, but that is the most effective way to treat neurotrophic ulcers in my practice.
Conj flap even better, actually.
Raj, are you doing these yourself? Are you suturing them, or if you?
I send them to my oculoplastics colleagues, and it can be done quickly, so easier than doing it myself to kind of solve Ed's issue.
Okay.
I have a question on the amniotic membrane. I agree. I would use a tarsorrhaphy here, but we have Procare that everyone can get and put in their office now. It's got a code. The Ambio Dry is saying you can cut out a little circle, put it in a contact lens, put it on the eye. When do you all use it, if you use amniotic membrane at all in the office? And is it something for the general ophthalmologist to pick up?
Yeah, I think it's easy to use, and it's
When do you use it?
well, I use it in the milder neurotrophic cases where I don't want to go right to a suture tarsorrhaphy or a tarsorrhaphy of other means.
Are you
so.
using Procare or the Ambio Dry?
I've used both, and I think it's tougher to get. The coating has gotten better, but you have to have a fridge to store it in. So I've tried ambio dry in those instances, and it's preliminarily worked, but you need to get a tight contact lens that fits so it doesn't slide under. All right, next case. This is a 44-year-old female with, again, history of severe dry eye, and has a new corneal ulceration, as you can see here in the periphery. This is a patient with peripheral ulcerative keratitis, and the diagnosis, actually, the question is, what's the diagnosis? I've given it to you, but blepharitis with sterile marginal infiltrate, acantholytic keratitis, Sjogren's syndrome, or HSV keratitis. So why don't you go ahead and respond? I've already told you it's a case of peripheral ulcerative keratitis. I've given you the answer. But more importantly, how are you going to manage this patient? Yeah. Doug?
Oh,
Are you awake?
57% said it's blepharitis.
Yeah. Interesting.
You're a great communicator.
You certainly, you're certainly going to treat the dry eye and everything that goes along with it. No antibiotic necessarily needed in this situation.
Amniotic membrane.
Amniotic membrane?
But,
All right, Ed.
this patient has Sjogren's disease with probably rheumatoid arthritis and secondary Sjogren's, but it's a necrotizing disease, and so this is, in cornea, one of the few true emergencies that we see. You can see in the color photograph there's actually scleral thinning off to the side, so it's a scleral keratitis, necrotizing disease. This patient needs systemic therapy quickly, and the most effective treatment is high-dose corticosteroids. And so we would consider talking to rheumatology and admitting the patient for high-dose IV steroids, a gram a day, things like that, and then needs local therapy. And again, it's a sterile melt. I mean, you might want to culture because of the infiltrate just to make sure there's not a secondary bacterial keratitis. So punctal occlusion, large tarsorrhaphy, and then don't forget about the fellow eye, because a lot of times this eye will go down to lose vision, and if you ignore the fellow eye is going to follow the same way. These patients need acute therapy with systemic corticosteroids, and then maintenance therapy with a second agent. Methotrexate is a very, very good long-term secondary agent. If the patient has a known diagnosis of rheumatoid arthritis, they may be already on something, and so, but this is a chance, again, to save an eye and to save a patient. There's some old studies by the guy in Boston, C. Foster. Untreated necrotizing scleral disease or corneal disease have about a 50% 5-year mortality because these patients have cardiac disease and renal disease, so this needs aggressive systemic therapy.
How about the cautionary note on topical steroid use in these patients? Because I've seen some come in on steroids.
Yeah, I don't start topical steroids as initial therapy because you can see rapid melt with these patients. But if they're on treatment and their epithelium is slow to heal and we have some infiltrate, you can add low-dose topical steroids and see the patient back frequently. Actually, topical cyclosporin is I think, a better choice for this patient.
Heather, any other comments that you'd...
Yeah, I think it's important to communicate with the rheumatologist, because if they're not on, I mean, you need their help, and if they're not on another systemic immunosuppressive agent besides prednisone already, like Ed said, they'll need to be. And then even when the ocular surface is healed, they need that long term. And if for example, the patient presents with this and you involve the rheumatologist to try and find an underlying autoimmune cause, if it's not diagnosed and they tell you that they can't find an autoimmune cause, they still need to be on the immunosuppressive agent long term.
Okay. Let's do one more case.
So this is a patient with irritation and foreign body sensation. The patient's been seen by numerous eye care professionals, and on examination you see this redundant area of inferior conjunctiva and really non-specific complaints, but your clinical diagnosis at the slit lamp is conj chalasis. So how do we want to treat this patient? Lubrication, topical steroids, conj resection, or conj resection and amnion membrane transplant? Please vote. All right, Dave, how do you want to treat this patient with long-standing conj chalasis?
Well, you know, if it's long-standing and I've ruled out everything else, I mean, the problem is you can see people with this kind of conjunctiva overlying the lower lid, and they really don't have symptoms. So when you see somebody with symptoms, you need to make sure that you've addressed everything else that it can be. But if you've convinced yourself that it's the conjunctiva, then it's fairly easy to resect, and I tend to resect it, and they tend to do pretty well. You can put an amniotic membrane on, but I think that is probably overkill in this situation.
You know, it's always been curious to me, and there's been several reports of putting amnion. I mean, the disease is too much tissue.
Right.
It's
There's no reason to add.
it's a functional, you know, disease of excess tissue, and so why would you take tissue out and then add more tissue in? Simply resecting it and then pulling up the cons to tighten it up takes away the symptoms. So I'm not quite sure why amnion has a role in this.
Is this like some of those eyes that have too much vitreous, and you need to get rid of some of those, too?
There you go. No, Woody, actually, this is another one in my practice of a severely underdiagnosed condition. These patients have been treated for blepharitis and dry for years and years and years, and they're miserable patients. When they blink, their conj hangs over the lid margin, and you do a conj resection on these patients, they're some of the happiest patients you ever see. So I think it's a significant disease, and it is very much undertreated. Now, I never recommend surgery on the first visit. You know, I sometimes start steroids and see the patient back, and I say, you know, we're going to make sure that this is the cause of your symptoms. We may treat dry, we may treat blepharitis, but if I see the patient on 2 or 3 visits and all I can see is persistent conjunctivitis, you can make the patient very happy. So I think it's a very significant disease.
I agree. I think it's overlooked, and I've had some milder cases that I've treated actually with conj cautery, you know, and you can just take a handheld cautery unit in your office with a lid speculum, and just by doing serial burns like a PRP pattern, you can tighten the conjunctiva. And then for the severe cases, I will go to conj resection.
And another variant is that we will sometimes, if patients doesn't want resection, which is my primary therapy, I will inject actually subconjunctival tobramycin, you know, from the old cataract days, and it will scar the conjunctiva down against the bulbar area, and that also can be very effective. But again, conjunctival resection, very easy. Do it right in the office, and it resolves the problem. And sometimes you won't see this. If you look at a patient at the slit lamp, you just won't see this. And you have to have the patient close their eyes. When they close their eyes, the lower lid will push the conjunctiva up, and it comes into view. And staining with lissamine green or rose bengal will sometimes show conjunctival staining in this area where the conjunctiva is exposed.
Can I ask you a question? Ed, for your technique, you said you excise the conjunctiva and then you pull it up?
Just tighten it.
So are you putting a suture in to hold it in place? You're putting glue? How are you keeping it up, or are you just leaving it there?
You know, if I can glue it, which I do a lot now with my conjunctival surgery, and it stays in position, well, otherwise 1 or 2 sutures to hold it in place.
Right.
Well, I want to thank our panelists for their excellent presentations.